here's what I'm going to do in this 20 minutes. As Joanna alluded to, there is a story about the evidence base, the evidence for the use of psychiatric drugs, which is so key to the current paradigm that we have. So I'm going to review really mostly what do we know about the long-term impact of psychiatric drugs. But real quickly, there are really three parts to the evidence base or two parts to the evidence base that is promoted to the public. The first part, of course, is the short-term trials, mostly funded by industry, in which you have the drug versus the placebo, and the drug is said to reduce the symptoms of the disorder better than placebo. There's a statistically significant difference. As Joanna mentioned, if you actually look at the difference between drug and placebo, it doesn't actually rise to the level of what's called a minimum clinically important difference, but it passes that statistical hurdle. Now, and that's all, it's that data that is cited saying we know these drugs are effective to the public. Now, the second part is, once you're on the drug, and let's talk about antipsychotics, what is the evidence for maintaining people on the drugs long term? And especially with the antipsychotics, they're known as relapse studies. And in these studies, what you do is you take good responders to the drug. It has to be a select population of good responders because their symptoms have to be under control at the beginning of this. And then you randomize them either to drug, it's just the drug they've been on and responding well to, or you withdraw the drug. And with great regularity, the people who are withdrawn, of course, relapse at a higher rate. And that is cited for the reason, the rationale, the efficacy for maintaining people on antipsychotics long term. And it's also sometimes cited for the efficacy for maintaining people on antidepressants. But you have to say, what is the flaw with the relapse studies? First of all, it's not talking about the group as an aggregate with that diagnosis. It's talking about good responders. That's a problem. The placebo group, it's not like the return of the disorder. They're going through withdrawal. That's a problem. And finally, what do the relapse studies tell you about the long-term impact on the course of people's lives? Does it tell how are the symptoms going at 1 year, 2 years? How are people functioning? What's their social lives like? It doesn't talk about that at all, okay? So those are the two parts of the evidence base that is cited for the use of psychiatric drugs. That's what's promoted. But there's a third part of the evidence base, and this is what I got interested in with Anatomy of an Epidemic. Well, first with Mad in America, but particularly with the Anatomy of an Epidemic. What do we know about the long-term impact of these classes of drugs, okay? And we know that people are on these drugs for years often. And so this is a key element that I think the public deserves to know. So you're not going to find randomized clinical trials that can tell you about the long-term impact. So what do you do? What is this sort of, what can be found in the research literature? What sort of approach can you do to flesh out what is the long-term impact of psychiatric drugs? And I'll give you a very quick story about antipsychotics, how you can do this. But the key thing here, even as you begin this talk, is this. You have to say, what is the natural capacity to recover from, say, depression or a psychotic episode? Because in order for your intervention to be beneficial, it has to beat whatever is the natural capacity to recover. Does that make sense? So, for example, imagine if, and this is just a hypothetical, imagine if you have a drug that over the long term does this. 50% of the people who come in are cured, and 50% stay the same as that baseline, okay? Now, every clinician is going to say, wow, my drug is helping, it's curing 50% of people. But you need to know what is the natural capacity to recover. And let's say the capacity to recover in nature is 85% will be well long term. Then with your intervention, you've still reduced the recovery rate, okay? So that's part of the foil for understanding this. So real quickly about antipsychotics. And I want to focus on antipsychotics because if there's any class of drugs that our society is led to believe are absolutely essential, both over the short term and long term, it's antipsychotics. So if there's any class of drugs that should have a firm evidence base for long-term use, it should be antipsychotics. So the first thing you need to try to do is, what were schizophrenia outcomes for first episode psychosis prior to when Thorazine arrives in asylum medicine in 1955? And you will find And by the way, this comes from an NIMH investigation in the 1950s trying to ask this question. You will find a surprise. From 1945 to 1955, about 2/3 of the patients diagnosed with schizophrenia would be discharged, first episode patients, would be discharged within 12 months. And if you followed up with that group, that cohort of first episode patients, to 3 and 5 years later, what percentage were living in the community? About 2/3. And this was before we had any disability system. So you actually saw people getting married, going back to work, that sort of thing. Now, in the conventional narrative, we heard that prior to the arrival of Thorazine, people couldn't live out in the community, right? And that Thorazine was what made it possible to empty the asylums and people live in the community. But you start with this, that's just not true. First episode people, 2/3, and you go into Norway and other countries, it's the same thing. About 2/3 would be discharged and living independently 3 to 5 years later. So that's the first data point. The next data point is, what did clinicians notice who had been used to treating people prior to the arrival of antipsychotics once they introduced it? And you can start seeing this in the research literature. Oh, maybe my patients are getting better a little faster, but boy, are they coming back to the hospital with great regularity. And they even invented a term, the revolving door syndrome, to describe this new course. Next, what do you see? In 1967, the NIMH funded a study to say, are we in fact improving the long-term course of these psychotic disorders? It was done by Samuel Bachhoven, and he had data from 1947, people treated with psychosocial care, but before the drugs, and he had 5-year outcome data for that cohort. He matched it with a cohort in 1967, treated with psychosocial care plus drugs, and here's what he found. At the end of 5 years, the relapse rate was higher with the 1967 cohort, and even more important, that they were much more socially dependent, much less able to function independently in society, okay? So that's another data point. Now, in the 1970s, the American National Institute of Mental Health funded 3 studies to basically, because there was big questions about antipsychotics now at this point and their long-term impact, funded 3 studies, they had a randomization element to see it compared drug treatment as usual to a form of care that might be a residential care, psychosocial care, and possibly selective use of medication, but no medication right away, okay? Now, in all 3 studies, one was 1 year, one was 2 years in length, one was 3 years in length. In all 3 studies, the alternative form of care that didn't involve immediate use of antipsychotics had better long-term outcomes, okay? In all 3. These were NIMH-funded studies. And then a man named William Carpenter, who is known as a real leader in schizophrenia research, and he did one of the 3 studies. He raised a really profound question. He said, now we know that once people are on the medications, they're less likely to relapse than if they stop taking the medication. That's the relapse studies, okay? But he says, but we have to ask, based on these 3 new studies, which you saw more psychotic symptoms in the medicated patients, do these drugs induce a biological change in the brain that makes patients more biologically vulnerable to psychosis? So the very drug that's being used to dampen those symptoms, now he's saying that maybe they cause a change that make people more prone to psychosis over the long term. Then in the early 1980s, 2 researchers from Canada, Guy Chenard and Barry Jones, says, we think we know what is happening. These drugs, as Joanna just mentioned, what the antipsychotics do is they block dopamine receptors in the brain. They're thwarting dopamine transmission. Now, because the brain is this extraordinarily neuroplastic organ, it goes through compensatory changes, trying to maintain what researchers said is a homeostatic equilibrium. So what happens, you go on the drugs, they block dopamine receptors, and your brain says, uh-oh, I need to compensate for that blockade, and it increases the density of its dopamine receptors. And so the researcher said, now you have a dopamine supersensitivity, and that has a couple effects. One, even if you stay on the drug, there's likelihood of more persistent, a sort of a tardive psychosis. 2, if you relapse, you might get more severe relapses than would be the case in the normal course of the illness. And 3, When you come off, now you're really vulnerable to relapse. So now this comes up in 1980, and you can see there's a crisis here, right? We've got a research, a road of research, a path in the research literature from NIMH-funded studies that says, uh-oh, maybe we have drugs that are making people more chronically ill over the long term, okay? Now, the year is 2025 now, so I hope I got the year right, but that's 45 years later, and now we have to say is, if we look at the research literature since that time, does it confirm this worry, or does it say that worry was not founded, and we don't have to worry about it, and especially in the era of the atypical antipsychotics, okay? So now what you're going to continue to do is you're going to try to find whatever evidence you can find of whatever type that bears on this question. So the next thing we have are cross-cultural studies by the World Health Organization. Twice they conducted studies of schizophrenia outcomes in 3 developing countries. That was India, Colombia, and Nigeria. And they compared those outcomes with outcomes in 6 developed countries, one of which was the US. The diagnoses were made by Western doctors, okay? So they standardized the diagnosis. Now, after the first study, and I think this was the 5-year study, they came up with a startling conclusion. They found that the outcomes were much better in the developing countries, specifically India and Nigeria, than in the US and the other developed countries. And they actually concluded, listen to this, that living in a developed country is a strong predictor you won't have a good outcome if you're diagnosed with schizophrenia. Which, by the way, was one of the findings that made me just want to investigate this whole story more. So now they're going to conduct a second study, and they make a hypothesis. And the hypothesis is this. One of the hypotheses, the primary one, is that maybe the reason for the better outcomes in the developing countries is the patients there are more medication compliant. They take their antipsychotics. Now, this is a valid hypothesis. If the drugs are supposed to be effective, medication compliance should be associated with better long-term outcomes, right? So what did they find? They found that in the 2 countries with by far the best outcomes, India and Nigeria, they used the drugs acutely but not chronically. Acutely means short-term, okay? In those countries, only 10% of patients were maintained on the drugs long-term, where, of course, in the developed countries, that's the standard of care. So that's another little data point that leads you to question this paradigm of care we have, right? Now, what happens in the 1990s? You get MRI technology. And that's a new thing that comes into medicine. And with MRI technology, what can you do? You can measure brain volumes. So Nancy Andreasen, beginning in the 1990s, and Nancy Andreasen was the editor-in-chief of the American Journal of Psychiatry. So what I'm trying to tell you here, this is their research, okay? This is mainstream research. I'm telling a history of NIMH-funded research, World Health Organization research, okay? This is not coming from the critics. So Nancy Andreasen had a hypothesis. She said schizophrenia, I think, is a neurodegenerative disease in the brain, and I bet she's going to see if there's going to be a diminishment in brain volumes over time, okay? She gets a young cohort, and I think it was a large study of about 500 people so diagnosed, and what she found is that there is a diminishment of brain volume over time, especially in the first year, okay? So she says the problem is, she's saying that is the disease, okay? That's her thought. And the problem is the drugs don't arrest that brain shrinkage. That's what she says. Then she comes out with a paper and says, as this shrinkage happens, you get a worsening of negative symptoms. That's the emotional retirement. You get a diminishment of cognitive function, and you get increased functional impairment. So that's her disease model. Now, the problem is, if someone did this, studied, and this is both the atypicals, the older drugs and the atypicals, did a study in macaque monkeys. Macaque monkeys don't have schizophrenia. And what did they find? They found this brain shrinkage, indicating it was drug-caused. Finally, Nancy Andreasen said, yeah, I went back to my data, it's drug-caused. So now what you have is another data point. If you really look about this, an agent comes in from the outside, it causes this brain shrinkage, and as that happens, you get a worsening of symptoms. That's actually what you see with a disease model. You know, by this I mean if you have a disease that actually caused brain shrinkage, you would see it in that light. Okay, next what we have is the best, how am I doing on time? How much time I got? What's that?
4 minutes.
Oh, I can't even see this, 4:37. I'm going to finish this up. We get the best longitudinal study that's been done in the psychiatric drug era. It was done by Martin Harrow and Thomas Job. What they did is they recruited 200 patients from two Chicago area hospitals, one public, one private. Everyone was, it's a naturalistic study, okay? Everyone is treated with drugs in the hospital, and then they're discharged, and they're just going to follow them up at 2 years, 4.5 years, 7.5, 10, 15, 20 years. One of their hypotheses, and at each follow-up, they're going to look at, are they using drugs? Are they symptomatic? What's their functioning, anxiety levels, cognitive? It's going to be a thorough assessment. And one of their hypothesis is actually, this dates back to the late 70s, early 80s, is those who remain on the medication will have better outcomes. So that's their hypothesis. Now, at the end, and there was 200 people they enrolled. There was 145 still in the study at the end of 15 years, 64 with a diagnosis of schizophrenia, 81 with a diagnosis of milder disorders. Now, at the end of 2 years, of the 64 schizophrenia patients, about 25 were off the drugs. And at the 2-year assessment, that group was doing a little bit better than the group on drugs. And then if you charted this out, if I had a graphic, you would see their outcomes diverge between year 2 and 4.5. And what did you see between year 2 and 4.5 and the group off? The recovery rates went up, whereas those on the drugs, they did not, such that by the end of 4.5 years, the recovery rate was 8 times higher for the group off medication. 40% were in recovery versus 5% for those on medication. That difference stayed all through the 15 years. And it was, and by the way, here's one interesting comparison. The people with schizophrenia off medication, in comparison to those who at the beginning had milder psychotic disorders that stayed on the medication, the group schizophrenia off had better outcomes than the milder disorders on long term. So what Martin Harrow said in 2008 at the American Psychiatric Association meeting, I conclude that schizophrenia patients off antipsychotic medication have significantly better global outcomes. Of course, that is not a finding that was promoted by the American Psychiatric Association. Now, finally, the beauty of this story is you can actually see a different use of antipsychotics that was pioneered in northern Finland with their open dialogue program that involved selective use. And what they did with their patients, they did not, and they reconceived the things. This is going to be the fastest 150 ever. They reconceived psychosis as not residing in the head of the individual, but in the in-between spaces between people. So you had to fix those spaces, help people become able to be with others. And they did not use antipsychotics right away because they thought people needed to have this emotional capacity to participate in these dialogical sessions. Anyway, beginning in 1992, this became the way they treated all their psychotic patients. And here were their 5-year outcomes. And they kept doing this. At the end of 5 years, 2/3 of their psychotic patients, first episode, had never been exposed to antipsychotics. And there was if people weren't getting better after a couple of initial weeks, they did put people on low doses. And then once they put people on low doses, they saw who could come off. Anyway, 2/3 never needed the drug. 13% needed them temporarily. And for whatever reason, about 20% needed to be on them long term. And what were their outcomes at the end of 5 years? 80% of their patients were working or back in school. And they've done 19-year outcomes. It's much lower cost. There is some sense of the open dialogue being exported around the world, but the problem is it's being exported without that selective drug use. So here's what I think this is the part of the evidence base that the public doesn't know. And the reason the public doesn't know it is that because it undercuts that narrative of effective drugs. And if you actually knew this long-term data, you would have to rethink that use, right, on a much more minimal basis. And I will say, 4 seconds. There's a man named Nasser Ghami. He was a very famous mood disorder psychiatrist. And he recently wrote There is no evidence that these drugs provide a long-term benefit. We should be using these drugs in as low a dosage as possible and for as short a period as possible. And just one last thing, because we're hearing about there is a lot of talk that's shifting. Okay, you see mainstream psychiatry saying we don't have evidence of long-term benefits. And Dost Unger, this past spring, who's the editor-in-chief of the JAMA Psychiatry, said, we have to, he says, the long-term outcomes for severe mental disorders have deteriorated in the last decade. So he was now he doesn't blame the drugs, he blames social conditions. But that's an acknowledgement that what is happening with this paradigm of care. We're getting worse outcomes, more disability, and that sets the stage, I think, for a real paradigm shift. That was the 20 minutes.